very much, Dr. Musa. Okay, good afternoon, everybody. It's a pleasure for me to be here today and to be able to participate in this meeting. It's going to be a step back now from the high stress complications and situation of the cath lab to old school medical management of patients. But patients that we've heard a lot of already today in yesterday's sessions, so our acute coronary syndrome patients. And it's a pleasure for me to be able to give you some of the insights from the EuroPath initiative. This is something that I've been involved with recently, which started out as an initiative between cardiologists in Europe, looking to optimize the post-ACS lipid management of patients. But this has now extended to involve countries in the Middle East as well. These are my disclosures. So what is the ACS EuroPath initiative? So it's a collaboration. Facilitated by Sanofi. It's a collaboration of various cardiologists initially across several European countries to discuss how we can improve lipid management in our acute coronary syndrome patients. So it's not a guideline initiation, or we're not writing guidelines, but we're looking at the established guidelines and seeing how we can implement the latest technologies and make sure that we are maximizing and optimizing the care of our ACS patients. So what were the principal goals of this EuroPath initiative? Number one is to improve the cardiovascular outcomes of ACS patients by optimizing guideline recommended lipid lowering approaches to achieve the lipid lowering LDL cholesterol goals. And number two is to cascade the optimal therapeutic pathways for LDL goal achievement to ensure broader implementation. So the idea is that by sharing our experiences, we all work in different countries, in different healthcare systems, with patients from different cultures and healthcare beliefs. But there is a commonality within that. And if we can share experiences, we can provide, hopefully, solutions that can be not necessarily applicable to all, but we can cherry pick the best so that we can tailor in our own healthcare systems, tailor the best way of optimizing the care of our patients. So this is the EuroPath story so far. It started in 2018 as really a discussion between cardiologists from several European countries. And the objective at that stage was really to align on the optimization of the ACS lipid management pathway. The key deliverable from that first meeting was the ACS European Pathway Survey. So this survey surveyed 555 cardiologists, involved nearly 3,000 data from 3,000 patients, and helped really just to establish the current landscape at that time. How good were we at managing lipid in our ACS patients? And that information was disseminated in a publication in atherosclerosis in 2020. The EuroPath movement moved on to EuroPath 2 in 2019, EuroPath 3, 2020-21, and most recently EuroPath 4 in 2022. In EuroPath 2, the objective was to share operational solutions to be able to translate the then hot off the press 2019 ESC guidelines for lipid management and see if we could translate that into clinical practice. And the key deliverable from that meeting was operational solutions to help cardiologists around the world, also using a self-assessment tool. So this was the ACS EuroPath lipid tool. And this was an online tool that you can all access that helps you to assess where you are in your current practice, benchmarked against the 2019 guidelines, with advice on how to improve practice. And then more recently, the EuroPath initiative has included all the other key stakeholders in how we manage lipids, primarily, of course, patients. And what became apparent is that patients are pretty unaware of how important lipid management is. They're certainly unaware of their LDL target goals, and so they're not really included and feel empowered in the whole process. And then also general practitioners. So in many healthcare systems, patients will see the cardiologist for their acute coronary syndrome, but then they're discharged into the community with no cardiology follow-up in many places. And so empowering and involving the GPs in the management of these patients with particular reference to their lipid management is really, really important. And what came out of many of these meetings is that GPs were pretty also unaware of lipid targets, current LDL goals for these patients, indeed the actual risk of the patient of recurrent events if we do not control their LDL cholesterol. So by incorporating or looking at this problem from a 360-degree perspective, we're able to provide complementary operational solutions for lipid management. And as I say, through each of these or following each of these meetings, there have been publications that are available, and future publications will focus on solutions for implementation of some of the Europath initiatives that have evolved from this. So if we focus on Europath 1, this was just the original survey. So this was back in 2018. How good are we at managing lipids in the ACS population? And the answer was not great, as you probably all know. So at that stage, only 67% of patients received high-intensity statin at discharge from their index ACS presentation. And there was great variation amongst the various European countries that were involved. Follow-up consultations were planned for approximately 80% of patients, but only half of patients had access to rehabilitation or secondary prevention programs in their institutions. If we look at follow-up, at first follow-up, 77% of patients had an LDL cholesterol target above 70 milligrams per deciliter, which was the then LDL goal for ACS patients. And among them, only 41% had no change to their lipid-lowering therapy. At second follow-up, 68% of patients were still not at their target LDL cholesterol of less than 70 milligrams per deciliter. And again, there was great variation amongst countries. So 44% of patients were not at goal in France, but 86% of patients were not at goal in the United Kingdom. And if we look at the bar charts on the right, I would just focus on the one at the bottom, which looks at treatment change in patients not at goal at their first follow-up. And 41% of patients had no change to their lipid-lowering therapy, which in simple terms seems to highlight some level of physician inertia at that first follow-up visit. If we look at Europath 2, the main deliverable from this was the self-assessment tool. And this is something I would encourage you all to perhaps access in your clinics or wherever, because it's a very useful tool to assess, almost like to audit your current practice. The tool incorporates three main areas. The first is a questionnaire to basically assess your lipid management practice, either individually or in your institution. It looks at the acute phase, so your lipid management during hospitalization, the discharge, so this section focuses on the follow-up plan, the LDL cholesterol goal at discharge, the discharge letter that's addressed to the GP, and the information provided to the patient. It focuses on follow-up, so lipid management at the time of the first follow-up and subsequent follow-ups, and the referral pathways. So what are the pathways that you or people in your team or the GPs have access to re-refer a patient with uncontrolled LDL cholesterol? So particularly perhaps patients with familial hypercholesterolemia or patients who are just struggling to achieve their target LDL. And then the final section looks at LDL levels achieved at 6 months to 1 year. This is what the tool looks like. I mean, I'm not going to focus on the individual bits, but it follows the acute phase, the discharge period, the follow-up phase, and then referral pathways for definitive lipid management in the care of ACS patients. And then you can have the overall outcomes at 6 months to 1 year and any key implications of that. And then you can see that it's benchmarked to the current guidelines, which still remain the 2019 ESC guidelines, and how you can assess your practice and what are the advice when it comes to the guidelines on how to perhaps improve your practice. So after Europath 2, there were also specific operational solutions that were devised in individual countries and sometimes in individual hospitals that provided some solutions that were helpful in those individual centers, where the lessons may well be helpful in your own centers. For example, The Penelope study from the Dutch Cardiovascular Research Network identified a key role for nurses in the outpatient clinic, where the implementation of close follow-up could be managed by nurses in the outpatient clinic. And that seems, is often quite a common theme, that doctors either feel they don't have the time or perhaps the inclination to check lipid profiles subsequently at follow-ups and to act on it. Whereas perhaps this can be a nurse-led facility. And that led to very high rates, 99% of very high-risk ACS patients reaching their lipid target, LDL cholesterol target, 3 months after their ACS event. In the UK, they used a multidisciplinary team format that looked at training nurses, again, to optimize the protocol in the cardiology department and the cardiac rehabilitation center. So using rehabilitation and that facility to follow up patients and to include lipids and lipid management as part of their MDT rehab pathway. In Italy, they used dual lipid lowering therapy at discharge as a strategy to achieve their target LDL cholesterol in patients as soon as possible post-discharge. In France, they used the same thing, and they realized that the application of this algorithm and the systematic use of high-intensity statin plus ezetimibe increased the early reduction of LDL cholesterol after ACS and allowed more patients to achieve their LDL goals. And importantly, that was a cost-effective strategy. And in Sweden, all patients in Sweden are entered into the Swede Heart Registry. And they found again that cardiac rehabilitation nurses who received accreditation to prescribe additional blood tests if needed, and the authority to adjust the lipid-lowering therapy treatment according to simple standardized steps, increase their patients or proportion of patients achieving their target LDL cholesterols, such that 54% of patients achieved an LDL of less than 1.8 millimoles per liter in 2014, but this increased to 82% in 2019. And by 2019, nearly 60% of post-MI patients had an LDL cholesterol of less than 1.4 millimoles per liter. So we move on to the Europath 3, and this was looking at a more holistic approach to lipid-lowering management. So involving the other stakeholders in this pathway. So not just the cardiologists who look after the patient in the hospital setting, but importantly, the GPs who manage the lipids in many countries exclusively once the patient has been discharged, and also the nurses who are involved at various stages, as well as, of course, the patients, shall I say. So looking at this sort of holistic 360-degree perspective, there were new unmet needs that were discovered. So inappropriate treatment prescription at discharge, lack of guidance in the discharge letter, inadequate lipid-lowering therapy optimization or any algorithm for escalation of therapy, gaps in the knowledge of clinical guidelines and lack of referral practices for GPs, so making it difficult or maybe even non-existent for GPs to re-refer patients back into the hospital setting to optimize the lipid lowering. And then patient concerns about blood lipid management. So some of the solutions that were devised by having this collaborative approach were a simple and pragmatic algorithm used by the hospital cardiologist during the acute phase to clarify the LDL target and the recommended treatments that would achieve that target. To provide a very clear template of standardized discharge letter, focusing on lipid-lowering therapies that's addressed to the GP. To provide a process or a tool enabling the assessment of lipid-lowering therapy efficacy by the cardiologist at 4 to 6 weeks according to the patient care. To provide education for GPs to generate a call to action, if you will, to ensure an effective post-ACS lipid management. So really disseminating the importance of lipid lowering, equipping and enabling GPs to understand the guidelines, be aware of the guidelines, and provide them with the tools of escalation. And then when it comes to patients, providing patient engagement discharge kits for all patients and recommendations for the healthcare professionals for the last briefing before discharge. So having a clear, simple, but comprehensive discharge letter that highlights the importance of lipid lowering, and taking some time in the hospital setting pre-discharge to talk through with the patient the importance of all of their medications, but including their statin and maybe ezetimibe or lipid-lowering therapy, and then the importance of getting that checked at a later date to optimize the levels. And through this kind of collaboration and combined discussion, through educational programs to practice sharing and sharing of experience, and perhaps through telemedicine guidance as well, we've developed solutions through these work streams to try and improve the implementation of the guidelines and therefore the attainment of the lipid-lowering goals for our ACS patients. So in summary, the Europath initiative started in 2018 and has engaged with experts, cardiologists from originally just European countries, but it's expanded now to involve the Middle East, to optimize post-ACS lipid management through a series of medical events as part of this ACS Europath Forum. Several local initiatives and protocols have been implemented across European regions to improve optimal management of patients with dyslipidemia. And what these have highlighted is that optimization of lipid-lowering therapies before discharge is important. Encouragement of treatment adherence and long-term maintenance need to be improved for the consistent attainment of LDL cholesterol targets. But therapeutic choices and personalized care will determine how well we achieve our LDL cholesterol goals in individual patients, and therefore should be included in standardized hospital protocols and discharge summaries. And the ACS Europath 3 initiative looks to build on these complementary operational solutions to drive change on by using holistic approaches involving all key stakeholders. With that, I thank you for your attention and we'll welcome any questions.
Thank you very much.